can read this.
Yeah.
So this is the research.
Yep, so carbon dioxide, DQ relationships, so an acid-base balance, and then this last one, control of ventilation. I think there are only 35 questions, so it's not as in-depth or detail as the previous two that had 50.
Not in.
Yeah, 40 questions. And one bonus.
I can always.
So wait, it's 35 or it's 45?
40.
Tabular gas equation?
40 with one
I know,
bonus.
right?
It's probably the content.
And I can tell you, I mean, the only thing we've calculated in in the last three chapters was the CO2 to the bicarbonate to carbonic acid ratio. Right? So I'll ask you to find a ratio of carbonic acid to
Yeah, but do we miss
bicarbonate.
Can we like learn how to do that really quick?
We did. We did it twice.
I'm sure it's in my notes.
And
It's not the law, right? Not the law.
what'll be great is when you're in clinical and you've got students following you in the next year and a half, and you'll say, oh yeah, Henderson-Hasselbalch. That's the PK plus the log base 10 of bicarbonate to carbonic acid.
Henderson Hasselbalch?
PK is 6.1. The log of bicarbonate, that's the normal value is 22 to 26 milliequivalents. Whoops. 22 to 26 milliequivalents. What's normal carbonic acid? That's simply the CO2 times 0.0301. Right, so if you're given a CO2, you can calculate, if you're given a blood gas, you can get the bicarbonate, you can calculate the carbonic acid, and then you can get the ratio. And remember, what the main point of this is that we suggested that if your ratio was anything but 20 to 1, it would cause an alteration in your pH, right? If it's higher than 21, what's the expected outcome? Higher than 20 to 1. So 21 to 1, 25 to 1, 30 to 1. pH is more alkalotic, yes indeed. If it's lower than 21, we have a acidic pH. And that we can just broadly make that comparison with the ratio in Henderson-Hasselbalch to an acidic or alkalotic pH. So if we understand that and we take that into next semester, we'll be ahead of the curve. So one bonus question. Majority of carbon dioxide is carried in the blood. Remember that diagram in it's the second part of chapter 6. CO2 transport. Let's see. So Megan would want to know, these are the exact questions. She asked me that last time.
Did I? Yeah,
Or
probably.
Lindsay
Sounds like
did.
something I would say.
Number 2, the ratio of bicarbonate to carbonic acid. Ratio of bicarbonate to carbonic acid. What did we circle 100 million times? What is that ratio supposed to be?
20 to 1.
20 to 1. Yeah, as long as it's 20 to 1, our pH will be within normal ranges. The fact that deoxygenated blood enhances the loading of carbon dioxide. So there are a couple different characteristics here. One's the Bohr effect, the other one's the Haldane effect. I want you to know the difference. The Bohr and the Haldane effect. The negative logarithm of the hydrogen ion concentration. That's Henderson-Hasselbalch, but what does it describe? What does it equal? Negative log of the hydrogen ion ratio. Right? So pH describes the inverse log of the hydrogen ion concentration. And that's why as hydrogen ions go up, the pH goes down, because it's the inverse log, the way it's described in as its definition. The amount of bicarbonate, the amount of carbonic acid present when the CO2 is equal to 100.
So times 0.03.
That's right. That's exactly right. So number 6, renal compensation. when does renal compensation occur? 24 to 48 hours, but it's in the face of respiratory acidosis will retain bicarbonate. A substance which donates hydrogen ions.
A substance that donate.
Yep. So an acid, carbonic acid, liberates hydrogen ions, right? It donates hydrogen ions. A base accepts hydrogen ions. So those are just definitional terms in the latter part of chapter 6, I think. The ability of an acid-base mixture to resist large changes. So what I try to have you do in this section is to try to relate what happens with the ventilation in terms of acidosis and alkalosis. So I give you a condition of acute alveolar hyperventilation. If we hyperventilate immediately, what would happen to the pH?
Go on.
You'd be alkalotic. So I want you to think about acid-base balance in terms of ventilation. Now that'll be really important next semester with mechanical ventilation and how you'll be adjusting ventilation parameters in an effort to normalize ABG results. So if a patient comes in with respiratory failure, your role is to put them on a ventilator and breathe for them to reduce the acidosis back to within normal limits. And you'll do that through intubation and mechanical ventilation. So this is where this makes a kind of a complete circle. Let's see. A compound which has the most profound influence on acid-base balance. A compound which has the most profound influence on acid-base balance.
Is this a buffer?
Here, what's that?
Is it talking about like the buffer?
No. If you're thinking about the central chemoreceptors, basically the amount of carbon dioxide influences ventilation. So, but carbon dioxide isn't specifically one of the responses. So we've got to figure out. You know, when we look at Henderson-Hesselbach, we've suggested that relationship is 20 parts of bicarbonate to every 1 part of carbonic acid. So the 1 part of carbonic acid has a profound influence. And carbonic acid is directly proportional to the amount of CO2 because we take CO2 times 0.0301 to get that ratio. So it's not CO2 particularly as much as it is carbonic acid. So that's an important distinction to understand, is that we're not measuring CO2 in particular, but we understand CO2 in acid-base balance to be an acid, and it influences pH. Number 12, severe metabolic acidosis. I mean, this is severe metabolic acidosis. Okay. 6.9, severe metabolic acidosis. Common causes of metabolic acidosis. The most important one for us is diabetic ketoacidosis. Amount of buffer base above normal. I don't recall if we've had a huge discussion, especially in ABGs, the buffer. How do we measure buffer on an ABG? Let me look and see if there was a level for base.
This
Yeah, this one right here.
Base excess.
Base was, yeah, base excess was minus 29. Holy cow. That's as high as I've ever seen a base excess.
What's it usually, like -2 or something?
It should be 0 to, it can be plus or minus, but usually it's around 0. If it's minus, that means, I mean, if you think about it, base excess is asking in the body system how much base is circulating that can help to cover or to reduce the influence of CO2. So base excess, usually we would see a positive we would report it as a positive number. Base excess. In this case, the base excess was minus 29, which means you didn't have an excessive base, you actually had a deficit, base deficit. In the text, I think they related both. And so I didn't want you to get confused. What the hell is a base excess in relation to a base deficit? Well, it's only thinking about it in a particular way about if it's positive or negative, right? So in this case, we had a base excess that was minus 29. If you have a base excess that's plus 10, what would you expect your pH to be? You have more base than you need. What would you expect your base? You'd expect your pH to be above 7.45. In this case, a minus base excess, we would expect our pH to be less than 7.35. And because it's minus, it should be 0, Armando, we would expect that minus 29, that would be really less than 7.35, which it was, 6.9. So, just an interesting statistic that I'll throw out there. You'll probably hear it again next semester. But in terms of pH, so if the range is 7.35 to 7.45, any change of 0.3. So if we change 7.35 to 7.65. We become alkalotic. That means that we've cut our hydrogen ions in half. So a change of 0.3 is reflected in halving our hydrogen ions. If it goes down to 7.15, we've changed our hydrogen ions to double.
Wait, do we need to know this for the test?
What's that?
Do we need to know this for the test?
No. But it's an interesting relationship with not only remembering the 20 to 1, but if your pH is 7, because we keep it in a shallow range, 7.35 to 7.45, if we change that to 7.15, so here we've doubled it again. So from a 6.9, we've almost quadrupled our hydrogen ions. So it just gives some relevance to the way that pH is measuring relationship to hydrogen ion concentration. And that hydrogen ion concentration is directly relative to how the impulses in the central chemoreceptors are influenced to respond. So if they have quadrupled the number of hydrogen ions with a 6.9 pH, that's why you can tell, I bet this guy's just hyperventilating like crazy, because the impulses are so strong to breathe. Okay. In the oxygen dissociation curve, it's a sigmoid curve, right? What about the carbon dioxide curve? How would we describe the appearance of that curve?
Linear.
Linear, absolutely. There's a direct relationship. The higher the CO2, the higher the content. So it's a linear relationship. Graphic illustration of carbon dioxide. Gas exchange between the systemic capillaries and the tissues.
Gas exchange like the CO2.
Yeah, just releasing CO2 and accepting oxygen. So if we exchange those gases in the systemic capillaries and the tissue, so we're just moving oxygen and carbon dioxide back and forth between cells. What's that called in terms of? I think there's a concept in chapter internal respiration. So in the chapter, it kind of describes the difference between what happens with moving gas from the external environment to your lungs. That's external respiration. That's why we never put anyone on a respirator. We always put patients on ventilators. So we don't ever respire for them. We always ventilate them. Next question, the ratio between the volume of oxygen consumed and the volume of carbon dioxide produced. How much oxygen do we consume in 1 minute? That's an easy one because it's from chapter 6.
What is it, sorry?
How much oxygen do we consume in 1 minute?
480?
We produce 1,000 milliliters, because that's described in oxygen content. We produce 1,000 milliliters, that's called oxygen delivery. What we deliver to the tissues is 1,000 milliliters. What the tissues actually consume is 25% of that, right? So that's 250 milliliters of the 1,000, that's a quarter, that's 25%. So we consume 250 milliliters of oxygen. We produce 200 milliliters of CO2. And that by its nature is called a respiratory quotient, or RQ. I can't remember what chapter that was in. So that's RQ. Number 18, VQ for, I guess this was in chapter 8. VQ ratio for a patient admitted with acute alveolar hypoventilation. So usually, if a patient's in respiratory failure, we want to try to remember what the VQ ratio is. So if ventilation is reduced, what overall happens to VQ ratio?
Patient admitted for acute what?
Respiratory hypoventilation. So the V part is lower. So what's the overall effect on VQ ratio? Yeah, it does. It diminishes. So think of ventilation in terms of a numerator, perfusion in terms of the denominator, and if you can insert numbers for what we consider normal, 4 liters of ventilation per minute, 5 liters of cardiac output per minute. If you can increase or decrease those numbers, you can get an overall idea of what's happening with VQ ratio. And all of the cardiopulmonary disorders, has Kelly gone over about 40 of them by now, I imagine?
What?
Right? 40 diseases? Quite a few.
Yeah.
So all of those diseases influence VQ ratio, every last one of them. Every pathology influences VQ ratio. Let's see. So acute alveolar hypoventilation. VQ ratio in the bases of the lungs compared to the apical segments of the lungs. So you want to compare what happens in the bases versus what happens in the tops. Respiratory quotient. So here's a question on the respiratory quotient. Getting more text messages than I need. Respiratory disorders which increase the VQ ratio. So now I'm asking you to make a leap in trying to determine which disorders can increase the VQ ratio. So under what conditions do we have better ventilation than perfusion? And I give you some pathologies, and I think I make a multiple out of that one. Under normal conditions, the respiratory exchange ratio is equal. Ventilation without perfusion, we looked at the difference between dead space and, what's the other one? Dead space and shunt. So you should be able to define what a shunt is and what dead space is. So in this case, ventilation without perfusion. Large portion of the lungs are perfused but not ventilated. What's the VQ ratio? So in this case, the perfusion is higher than ventilation. What happens to the VQ ratio? Goes down. So it's kind of confusing to have to think. Okay, yes, exactly. That's the easiest way to make sense of it. VQ ratio. Blood gas results for acute case of alveolar hyperventilation. So alveolar hyperventilation would necessarily include a low CO2. If you're hyperventilating, CO2 goes down. That would be a respiratory alkalosis. So probably uncompensated respiratory alkalosis, right, if it's an acute case. Perfusion without ventilation, that's the opposite of that previous question. Reflex that is generated by stretch receptors.
The yawn noise.
Yeah.
What's the name, Jimmy?
I don't remember.
Doesn't help.
Peripheral chemoreceptors are specifically sensitive to this substance. Chronic obstructive lung disease, chemoreceptors which may have complete control of ventilation. In COPD, which receptors have complete control? May have complete control. Peripheral specifically, the oxygen sensitive cells. That's why we have to be careful when we administer oxygen to COPD patients, is that not all of them will respond that way, but we have to be aware that there are some that will. Oxygen-induced hypoventilation. Prolonged gasping type inspiratory maneuver.
Sorry, what was that?
A prolonged gasping type respiratory maneuver. So it's controlled by the pneumotaxic center. Where the centers are located, so you should be familiar which ones are in the pons, which ones are in the medulla. Voluntary signals, semi-permeable membrane which separates the blood from the cerebral spinal fluid.
Mhm.
Mhm.
I didn't hear it, so.
The response to an acidic pH in the CSF, substance which accepts hydrogen ions. So it donates hydrogen ions and accepts hydrogen ions. That's back to chapter 6. Carbon dioxide is hydrated with an enzyme. So how do we make this shift with CO2? I guess I've erased it. If CO2 is hydrated with water, what is it that helps to make that shift to carbonic acid? Look that one up. There's something here that will help make that shift. It's an enzyme. Response to an acidic pH, substance which accepts hydrogen ions. Carbon dioxide is hydrated with an enzyme. Most powerful effect on the respiratory component in the medulla. So that's on the VRGs. And last question, central chemoreceptors are located where? Yep. Yep, sure enough. So 40 questions, the last 3 chapters. That'll get us most of the way through the text. Next time we'll just do the renal system. So any I don't want to clutter, having just done the review for the last 3 chapters, I don't want to clutter that up with too much renal stuff. But I also want to answer any questions, so maybe if you jump up and run around, and then we'll entertain questions about the renal system.